Welcome to Section 15 of the Renal Physiology Review. In Section 15, we will walk through the different diuretics, going through their site of action, as well as their clinical indications and the associated metabolic findings that are seen with each of their use. Welcome to Section 15 of the Renal Physiology Review. In Section 15, we will go over the clinically used diuretics and where they act throughout the nephron. Some general concepts to remember when reviewing diuretics. Diuretics are used to decrease extracellular fluid volume. They all act by inhibiting the reabsorption of sodium. Inhibition of sodium thus leads to decrease in extracellular fluid volume. The inhibition of sodium reabsorption proximally increases delivery of the sodium to the distal nephron. This mechanism is important to remember when predicting the effects on other ions. The potency of a diuretic depends on the following: the resorptive capacity of sodium for the nephron segment inhibited, the resorptive capacity of segments distal to the site of action. Based on this, one would expect that proximal tubule diuretics would be the most potent. However, because of the segments distal to the proximal tubule and their high reabsorptive capacity, loop diuretics are actually the most potent diuretics, followed by thiazide diuretics. All other diuretics are less potent and often more used for specific clinical indications. Diuretics are classified by where they act in the kidney. There are proximal convoluted tubule diuretics, specifically the carbonic anhydrous inhibitors or osmotic diuretics. There are loop diuretics, which work in the thick ascending limb of the loop of Henle. There are thiazide-type diuretics, which work in the DCT. Finally, there are potassium-sparing diuretics, which work in the cortical collecting duct. ADH inhibitors are included in this list. However, they are not diuretics in the truest form, in that they don't affect sodium reabsorption. ADH inhibitors specifically impair water reabsorption. The net effect is still decreasing extracellular fluid volume. However, it is important to note this distinction. Once again, a review of the renal tubule with the site of action of different diuretics listed. You can see here, number 1, acetazolamide acts in the proximal tubule. Osmotic agents also act in the proximal tubule. Loop diuretics act in the thick ascending limb on the sodium-potassium 2-chloride cotransporter. Thiazide-type diuretics work primarily in the distal convoluted tubule. Aldosterone antagonists in the collecting duct, and ADH antagonists in the medullary collecting duct. We're going to go over each of these in much more detail. First, the carbonic anhydrous inhibitors. Carbonic anhydrous inhibitors work on the proximal tubule. As we talked about before, reabsorption of sodium and bicarbonate in the proximal tubule are coupled. Bicarbonate is reabsorbed in the form of carbon dioxide. The conversion of bicarb to and from carbon dioxide requires carbonic anhydrase activity. Thus, if carbonic anhydrase activity is impaired, bicarbonate reabsorption is also impaired. Let's walk through this in more detail. If you administer acetazolamide, which is a carbonic anhydrous inhibitor, the reaction of bicarbonate coupled with hydrogen to form carbonic acid is inhibited. This then decreases the carbon dioxide that diffuses into the cell, which then decreases the amount of bicarbonate and hydrogen ion formed. This hydrogen ion is necessary for the sodium-hydrogen exchanger. The end result is decreased sodium-hydrogen exchange activity, thus leading to decreased sodium reabsorption activity. The other effects we see are there are increased urinary bicarbonate losses because the means for reabsorbing bicarbonate have been inhibited. This leads to a metabolic acidosis. There is also increased distal delivery of sodium to the collecting duct. The compensatory mechanism, activation of the aldosterone system, increases sodium reabsorption distally in exchange for increased potassium losses. Thus, we also see hypokalemia. Because of inhibition of sodium reabsorption in the proximal convoluted tubule, there is thus decreased water reabsorption as well. Given that water reabsorption is necessary for other ion reabsorption through solvent drag, another manifestation seen is increased urinary calcium losses, and extreme forms, hypocalcemia. The prototype of carbonic anhydrase inhibitors is acetazolamide. The major clinical use is the treatment and prevention of altitude sickness. Another use is glaucoma. However, this in clinical practice is rarely ever used as a diuretic, primarily because although it affects the proximal tubule, which is mostly responsible for sodium reabsorption, the more distal segments of the nephron, the thick ascending limb and the distal convoluted tubule, compensate and reabsorb much of the sodium that is lost. Therefore, its overall effect as a natriuretic or diuretic is very small. Osmotic agents can also be used as diuretics. These are much less used clinically often, even less than the carbonic anhydrase inhibitors. The primary osmotic agents that are administered are mannitol and other osmotically active molecules. Osmotic agents prevent the normal reabsorption of water that occurs in the proximal tubule driven by sodium reabsorption. Thus, there's increased water left in the urinary space and increased water losses as that water goes past the proximal tubule into the later distal segments. Because of the decreased water reabsorption, there is also decreased absorption of other electrolytes that usually move along with water by solvent drag. So once again, sodium, potassium, and calcium losses are increased in the urine. The effects of osmotic diuretics is lead to a decreased effect of circulating volume, a contraction alkalosis, hypokalemia, and hypocalcemia. Once again, the prototype is mannitol. The major clinical use is in the setting of cerebral edema or elevated intracranial pressure. The reason for its use is that it increases the osmolality of the plasma, which allows water to shift from the intracellular to the extracellular compartment, thereby lowering intracerebral pressure. Other uses are with acute angle closure glaucoma, also rarely in the setting of renal failure. Primarily this used to be used in the setting of rhabdomyolysis to prevent myoglobin precipitation in the renal tubules. More recently, this is found to be perhaps more dangerous than useful, and thus it is no longer used clinically. For the purposes of the Step 1 exam, the important thing to remember is that mannitol works primarily to decrease water reabsorption, leading to increased water and salt losses, and its primary use is in the treatment of increased intracranial pressure. Loop diuretics are certainly the most commonly administered diuretics in a clinical setting, and from the standpoint of USMLE Step 1, understanding their mechanism and their site of action is extremely important. The site of action is in the thick ascending limb of loop of Henle, and this specifically inhibits the sodium-potassium 2-chloride cotransporter. The effects are increased sodium and thus water losses. As we said, the activity of the sodium-potassium 2-chloride cotransporter allows for the generation of the hypertonic interstitium and thus the water reabsorption in the thin descending loop of Henle. However, if the sodium-potassium 2-chloride transporter is inactivated, there is less of a gradient to drive water reabsorption in the thin descending limb. The end result is the impaired ability of the kidney to concentrate urine normally. Also, however, because the thick ascending limb is one of the diluting segments of the kidney, inhibition of the sodium-potassium 2-chloride cotransporter leads to inability of the kidney to maximally dilute urine. The end result is decreased ability to both concentrate and dilute urine. Thus, urine created as a result of loop diuretic administration is usually isoosmolar. The other results of inhibition of the sodium-potassium 2-chloride transporter are what you'd expect from any other proximal diuretic, in that there is increased distal sodium delivery, which activates the renin-angiotensin-aldosterone system, which activates the sodium epithelial channel in the collecting duct, increasing sodium reabsorption in the collecting duct and leads to increased potassium losses. Also, the recycling of potassium back into the tubular lumen is dependent on the reabsorption of the potassium through the sodium-potassium 2-chloride cotransporter. If this channel is inactivated, potassium no longer has a stimulus to drive back into the tubular lumen. Without potassium present, there is no lumen-positive voltage that would otherwise drive calcium, magnesium, sodium, and potassium reabsorption. Thus, the end result is increased urinary losses of not only sodium and potassium, but also calcium and magnesium. This becomes extremely clinically relevant in that the treatment of hypercalcemia includes the administration of a loop diuretic to increase urinary calcium losses. Also, in patients that are using either acutely or chronically loop diuretics, they will often see not only hypokalemia, but also low serum magnesium levels. As with other diuretics, loop diuretics will decrease effective circulating volume, leading to a contraction alkalosis. The prototype of loop diuretic is furosemide, also known as Lasix. This diuretic is most commonly used to treat any edematous state, heart failure, cirrhosis, nephrotic syndrome, as well as renal failure. It can be also used as an adjunct in treatment of hypertension. Thiazide-type diuretics act in the distal convoluted tubule. Thiazide-type diuretics act on the sodium chloride cotransporter present in the DCT. As with other diuretics, it'll increase urinary sodium loss. Also, as with other diuretics, it'll increase distal sodium delivery, leading to hypokalemia through activation of aldosterone activity. One thing important clinically to remember is that through a complex mechanism, thiazide diuretic administration increases renal tubular calcium reabsorption. This is the only diuretic that causes hypercalcemia. The exact mechanism is not important to remember, simply to remember that thiazide diuretics will increase serum calcium levels. The other thing importantly to remember is that the distal convoluted tubule serves as one of the diluting segments of the tubule. Administration of thiazide diuretics, especially in the elderly, can lead to hyponatremia, especially in the setting of low solute intake. Remember, the distal convoluted tubule serves as a diluting segment. In the absence of sodium chloride cotransport activity, urine cannot be diluted appropriately, and excess water reabsorption may occur. This can lead to hyponatremia, often clinically relevant. The prototype of thiazide diuretics is hydrochlorothiazide. The major clinical use is that it is the first line in the treatment of isolated hypertension. Thiazide-type diuretics decrease blood pressure via decreasing effective circulating volume, as well as vasodilatory properties that are not well understood. Oftentimes they're used with loop diuretics in treatment of edematous states. Important to remember is that with chronic administration of loop diuretics, there is increased sodium delivery to the distal convoluted tubule. While normally the DCT plays a small role in sodium reabsorption, it has been demonstrated in multiple studies that chronic increased delivery of sodium to the DCT can cause hypertrophy of the sodium chloride cotransporter and can allow for increased reabsorption of sodium chloride in this segment. Therefore, in someone with chronic loop diuretic administration who becomes diuretic resistant or has decreased effect of the same dose of loop diuretic, oftentimes the addition of a thiazide-type diuretic can be extremely useful to increase natriuresis and diuresis. Other uses of thiazide diuretics is that they can help prevent calcium-based renal stones because of their effect of increasing urinary calcium reabsorption and decreasing urinary calcium. Finally, they can be used in the treatment of diabetes insipidus because of the inhibition of the diluting capacity of the DCT, similarly in the way that can lead to hyponatremia. Once again, for the purposes of the STEP exam, the important features to remember are that they're the first-line treatment in the setting of isolated hypertension, and also they are the only diuretic that leads to increased serum calcium levels. Lastly, potassium-sparing diuretics. Their site of action is the cortical collecting duct, primarily on the epithelial-sodium channel. There are two major types. One are direct aldosterone antagonists. The others are direct blockers of the epithelial-sodium channel. As we said, aldosterone activity stimulates both the synthesis as well as the activity of the epithelial-sodium channel on the luminal side of the principal cell. When aldosterone activity is inhibited, there is decreased synthesis as well as activity of this sodium channel. The sodium is reabsorbed less. Also, what the other result is that there is decreased urinary potassium excretion. This is how these diuretics can lead to an increase in serum potassium concentration, and why they're referred to as potassium-sparing diuretics. Epithelial sodium channel blockers directly block the sodium channel, but have the same effect in terms of decreasing sodium reabsorption as well as decreasing potassium excretion. The major clinical manifestation, as mentioned, that we can see with potassium-sparing diuretics is true and in some cases life-threatening hyperkalemia, especially in the setting of other drugs that may inhibit urinary potassium excretion, such as ACE inhibitors or angiotensin receptor blockers. Also, the decreased sodium reabsorption can lead to decreased hydrogen secretion, which can lead to a mild metabolic acidosis, although this is less seen in the clinical setting. The prototypes of potassium-sparing diuretics are aldosterone antagonists, also known as spironolactone or eplerenone, as well as the direct sodium channel blockers, the prototype being amiloride. By themselves, they tend to be weak diuretics because at normal levels, the collecting duct plays a much smaller role in the reabsorption of sodium. However, they are often used to treat the hypokalemia that results from the administration of diuretics that act in more proximal segments of the nephron. Also, spironolactone itself is used in the setting of advanced congestive heart failure. There are a few studies that suggest that because of the increased aldosterone activity in the setting of heart failure, that the administration of direct aldosterone antagonists can improve heart failure survival. It's extremely important, however, to remember that life-threatening hyperkalemia can occur and must be monitored closely. Lastly, although categorized with diuretics, ADH inhibitors are not diuretics in the classic sense, in that they do not increase the excretion of sodium. What they do, however, is increase free water excretion, and they're particularly useful in the treatment of hyponatremia. As we stated before, ADH primarily acts in the medullary collecting duct to increase the presence of aquaporins, or water reabsorptive channels. The agents that are currently in existence are either direct V2 antagonists or antibiotics that have been developed that can act as vasopressin antagonists. Demeclocycline is the oldest such form. It is a tetracycline antibiotic that can be used in adjunction to free water restriction in the treatment of SIADH. Because the chronic administration of demeclocycline can lead to nephrotoxicity, its use is less and less common. The new class of drugs that has recently been developed and released are the direct V2 vasopressin antagonists. Conivaptan is the prototype of this. It's used often in the treatment of euvolemic hyponatremia, such as an SIADH, as well as hypervolemic hyponatremia, such as congestive heart failure, cirrhosis, or nephrotic syndrome. Conivaptan blocks ADH binding to the V2 receptor, which prevents aquaporin insertion into the luminal membrane, thus inhibiting water reabsorption and the hyponatremia that may result from this. Let's just go through the effects of diuretics on potassium. In normal physiology, potassium secretion in the cortical collecting duct is coupled to sodium reabsorption, as we've said. This is how hypokalemia is a result of all the diuretic use except for diuretics that act specifically in the collecting duct. With increased distal delivery of sodium, the increase sodium losses, volume depletion, and activation of the renin-angiotensin-aldosterone system. This leads to increased sodium reabsorption in the cortical collecting duct, which leads to increased potassium secretion. In contrast, diuretics that act on the sodium channel in the collecting duct will lead to hyperkalemia, in that this is otherwise the mechanism where urinary potassium excretion can be increased. As with potassium, most of the diuretics have the same effect on urinary calcium excretion outside of thiazide-type diuretics. Normally, calcium reabsorption in the proximal convoluted tubule and thick ascending limb is coupled to sodium reabsorption. In the proximal convoluted tubule, this occurs by a solute drag. As you recall, sodium reabsorption occurs, water follows the sodium, and the other electrolytes abundant in the water, such as calcium, follow along. In the thick ascending limb, the generation of the lumen-positive voltage through the back leak of potassium facilitates increased calcium reabsorption. Therefore, both proximal tubular as well as diuretics that act in the thick ascending limb increase urinary calcium loss. In contrast, thiazide-type diuretics that act in the distal convoluted tubule on the sodium chloride cotransporter increase calcium reabsorption. How this exactly occurs is not entirely well understood, but the ultimate result is that thiazide diuretics are the only type of diuretics that can lead to hypercalcemia. Lastly, let's explore the acid-base effects of diuretic administration. This depends on the site of the diuretic action. In the proximal tubular diuretics, primarily carbonic anhydrase inhibitors, because they impair bicarbonate reabsorption, will lead to, in the end, metabolic acidosis. The other types of diuretics, as they decrease effective circulating volume, lead to a contraction alkalosis. The greatest alkalosis occurs with the most potent diuretics, loop diuretics and thiazides, which produce the most significant drop in extracellular fluid volume. Potassium-sparing diuretics that act in the cortical collecting duct, because they inhibit sodium reabsorption, they may also lead to decreased hydrogen secretion, and thus lead to a mild metabolic acidosis. Let's go through a few questions. Which of the following diuretics is not associated with hypokalemia? A. Acetazolamide, B. Furosemide, C. Hydrochlorothiazide, D. Amiloride, or E. Mannitol. The answer, of course, is D. Amiloride. All the other diuretics lead to increased distal sodium delivery, which then thus leads to increased sodium reabsorption in the collecting duct, which will lead to increased urinary potassium losses. Amiloride, given that they act on the collecting duct and the sodium channel, will not have the same effect on urinary potassium excretion, and also can in fact lead to hyperkalemia. Question 17. A 76-year-old male with a past medical history of hypertension and congestive heart failure presents with dyspnea on exertion. He is found to have pulmonary edema on chest X-ray. His plasma sodium level is 126 milliequivalents per liter. Which diuretic should not be used in this patient? A. Spironolactone, B. Furosemide, C. Hydrochlorothiazide, and D. Amiloride. The answer be C. Hydrochlorothiazide. As we said, hydrochlorothiazide acts on the distal convoluted tubule, one of the diluting segments of the nephron. When the distal convoluted tubule activity is decreased, the urinary diluting capacity is also decreased, and less free water can be excreted. This could aggravate already pre-existing hyponatremia. Question 18. A 64-year-old woman with a history of advanced breast cancer with metastasis to the bone presents to your office with a recurrent history of hypercalcemia. Which of the following diuretics would be most appropriate to use in this patient? A. Acetazolamide, B. Furosemide, C. Hydrochlorothiazide, or D. Mannitol. The answer would be B. Furosemide. As we stated before, furosemide acts on the thick ascending limb, blocking the sodium-potassium 2-chloride cotransporter. This activity usually leads to the shuttling of potassium back into the tubular lumen, facilitating the reabsorption of calcium among other electrolytes. When the sodium potassium 2-chloride cotransporter is inactivated, this potassium shuttling does not occur, and calcium is not reabsorbed in the same fashion. Thus, urinary calcium losses are increased. This is how furosemide is an effective treatment for hypercalcemia. The take-home points to remember from the review of diuretics is that diuretics have different sites of action throughout the nephron. The associated metabolic abnormalities seen with each of their use is dependent on the site of their action. Linking the physiology, renal transport, and the site of action of the diuretics will allow you to best understand the indications for different diuretics as well as the associated findings with each of their use. This concludes both the section and the renal physiology online review course. The take-home points to remember from the review of diuretics is that diuretics have different sites of action throughout the nephron. The associated metabolic abnormalities seen with each of their use is dependent on the site of their action. Linking the physiology, renal transport, and the site of action of the diuretics will allow you to best understand the indications for different diuretics as well as the associated findings with each of their use. This concludes both the section and the renal physiology online review course. The take-home points to remember from the review of diuretics is that diuretics have different sites of action throughout the nephron. The associated metabolic abnormalities seen with each of their use is dependent on the site of their action. Linking the physiology, renal transport, and the site of action of the diuretics will allow you to best understand the indications for different diuretics as well as the associated findings with each of their use. This concludes both the section and the renal physiology online review course.